Welcome back to Medical Monday. If you're just joining us, a couple of topics for you tonight. We're talking about holiday blues, also depression and pain and how they go together. Dr. Draud here with me, local psychiatrist. So thank you for coming in.
Happy to be here.
Super appreciate it. Want to remind you, we are taking calls tonight, 615-737+. We'll get those lined up, and if we have them, we will take them. I can assure you of that. In the meantime, I do want to continue this discussion on chronic pain and depression, how they usually go hand in hand. And we were just getting into treatments. And you had mentioned the opioid crisis, and I know that has to be in your mind with every treatment plan you come up with.
Right. So obviously this has become a, quote, epidemic, you know, with respect to the opioid crisis. And last I read was, it's been a month, I will say, but the last figure I read was that there are 81 either accidental or intentional deaths by opioid overdose per day.
Wow.
In the U.S.
81.
Yeah.
81.
Either accidental or intentional. And so again, this discussion around adequately treating pain and depression to avoid opioid excess, whether it be recreational or otherwise, is a significant one. So, you know, let's take, for example, well, let's just take, for example, the person who begins to abuse opioids. Let's say they don't have a chronic pain syndrome.
Okay.
Many patients who abuse opioids or alcohol or other drugs are actually self-medicating an underlying psychiatric illness. So many patients with depression or anxiety, let's take depression first. Patients with depression will often self-medicate with either alcohol or sometimes stimulants to help
counteract,
bring them out of the depression with a stimulant. Alcohol is euphorogenic to most people at the beginning, as in the first drink or so, but then it becomes depressogenic as time goes on. So it's really defeating the purpose after when it becomes an excessive, you know, thing. On the anxiety end of the spectrum, people tend to self-medicate with sedatives. Whether they
calm them
be
down.
Right. Of course, alcohol, opioids, other kind of nerve pills, Xanax, Valium, etc., things of that nature. So people tend to use those to self-medicate anxiety. And a lot of people get addicted to prescription drugs because of having an underlying psychiatric disorder untreated, either unrecognized and or untreated. Not everybody. Some people simply abuse drugs.
Sure. Yeah,
but
we know that.
Interestingly, when I go through, you know, when I take patient histories and try to help people who've become addicted get out of it, if you trace back, many of them have had a primary psychiatric disorder that was never treated. And then they fell into, you know, abuse of other substances. Now, the other way is also valid. So let's say you do have a legitimate pain syndrome for which opioid treatment is indicated. Whether you abuse the opioid treatment or not, you can become dependent, and chronic opioid therapy is depressogenic. So people that take opioids over a chronic period of time, many times become chemically depressed.
Wow.
From the medicine that they're being treated for a legitimate pain syndrome with. Hence this important understanding of the two disease states and the interplay between. So as I mentioned earlier, you know, some of my colleagues and I are kind of putting our heads together to try to treat both ends of the spectrum.
I kind of imagine it's like peeling away an onion, but also trying to do a maze.
Yeah.
To find the solution.
And no one case is alike, you know, or no two cases are alike, I should say. So it's very complicated.
Yeah.
You know, and you know, opioids are probably among the most habit-forming substances we have. I mean, some people remember, but some may have forgotten that the opioid abuse is what brought down the Roman Empire.
Did not know that.
So they had an aqueductal system. They had a complex society, in many ways as complex as ours is today, you know, many hundreds of years ago. but they sat around in those in those palaces and smoked opium. You've heard of opium dens. So this goes way back to, you know, to those times, and that is what theoretically we believe was the fall of the Roman Empire. Was an opiate addiction, an opiate abuse epidemic.
And then you mentioned numbers like 81 people a day across the United States, and you just wonder, is history repeating itself?
Right, and it's a complicated situation because the government is cracking down on pain pill abuse, if you will.
Right.
And I don't know, again, you may or may not know, our viewers may not know, but the #1 abused opioid currently in the U.S. is heroin.
Right.
Because it's cheaper.
Yes. And
the opioids are being limited in terms of prescription use, so that they're not available for resale or abuse, if you will. So people are turning to a cheap, available alternative, which is heroin.
Yes, which is being cut in with different things and becoming even more deadly than just heroin.
These accidental deaths, because people are using these drugs of abuse as, you know, as recreational, not really knowing what's in them. And there's a term in medicine called a narrow therapeutic window, which just means you can be taking a drug and taking it, and really not know that it's too late. So you can take so much of an opiate to suppress your respiratory drive to the extent that you die, not necessarily trying to die, just trying to use more drug to either achieve pain control or a euphorogenic effect. And you can literally kill yourself accidentally without knowing it.
It's very scary, and it's a reality for many families right now in our area.
Right. We all, I mean, it's now become such a commonplace thing that nearly everybody knows either a family member or a very close friend who has a family member who has been touched by this, either to the extent where a loved one goes into treatment or has died.
Yes. Yeah.
I mean, we all can think of probably 5 people right off the top of our heads that are either, you know, whose lives have been changed forever because of this epidemic.
So I want to talk about treatments that do work, but first I want to get to Gladys, who's hanging on the line. Gladys, thanks for being part of the show. What's your call tonight, or what's your question?
I'm 88 years old, and every week or two I have problems that I don't sleep all night long. And I have been on Xanax for anxiety, and most of the time I only take one, the low dose each night, and seems like I sleep better, but still there are times that I can't sleep, and it'll be foolish things on my mind, not problems. Sometimes it's what I'm going to do the next day, or will I be able to do this or that. I have this problem sleeping, and I'm wondering if it could be from depression. I have pain also in my hands with carpal tunnel, and sometimes that bothers me, but my problem is I can't have periods I can't sleep.
Sure. All right, Dr. Draud, any advice for Gladys?
So yes, certainly if you're having ongoing pain, that can affect your sleep. Xanax is a particularly poor choice for sleep because it has what we call a short half-life, meaning that it kicks in and helps you go to sleep, but then it kicks out 4 to 5 hours later. So if chronic insomnia is an issue for you, that's not a great choice. So what I would recommend you do is talk to your doctor, look at some other sleep remedies that have longer half-lives, in other words, that are not as psychoactive. Xanax is also you know, benzodiazepines like Xanax and Valium and drugs of that class are particularly problematic in patients over 60, and they are known to, interestingly, predispose to dementia. So there's a lot of new research that shows that especially, not all patients, but especially older patients, should be very wary of drugs like Xanax and Valium because of the effects they have on cognitive functioning, as well as balance. So people who take those kinds of medicines, who get up to go to the restroom in the night, have a higher likelihood of falling. So anyway, I think, like with many things, go back to the drawing board, speak to your doctor, tell him you'd like to consider a safer and more effective remedy for sleep.
Okay, Gladys, that should give you a good jumping point. You mentioned first, you should always start with your primary care doctor, and I am not faulting primary care doctors at all. They see a variety, I mean, the list goes from A to Z, quite literally. But when it comes to pain management, considering the opioid crisis, you know, age and everything else that factors in, is there someone she should go beyond that if she's not getting satisfactory? You know, because she doesn't know whether, you know, Xanax is good for her at 88 or not. She's relying on a doctor.
Right, right. Well, if the pain is really the major issue, then a pain clinic evaluation would be a wise thing. If depression, which she mentioned, is an idea that needs more vetting, then probably a psychiatrist would be a good idea to fully look at that. Because again, we're talking about this bidirectional relationship.
Right.
So she's telling us she has chronic pain. She's wondering if she has depression, which then, both of which can cause insomnia. And then we haven't even gotten into that whole topic, but insomnia makes pain worse, makes depression worse. So if a person presents, to me anyway, with both significant depression and insomnia on visit 1, it's rare in medicine that we like to prescribe 2 medications simultaneously because it's hard to know what one is doing.
Sure.
However, comorbid depression and insomnia are very bad bedfellows, as they say, because without treating them both, neither will get better. So the relationship between depression and insomnia is every bit as vetted as the one between depression and pain. And then you start to triangulate, and you can have all 3. So it's not simple, and unfortunately, you know, medicine is not a simple art to practice, so to speak, because people are not usually as simple as, oh, I have this one problem. Right. Well, that one problem leads to 2 or 3 others, and without treating the full spectrum, it can be really difficult to get to the bottom. So in her case, what I would actually do is pick, if I were going to pick one medicine to start with, I would pick a pain modulating antidepressant that induces sleep.
What is that?
Well, there are several. You know, there are the classic one goes back to the 50s. It's called amitriptyline or Elavil, and at a very low dose. Again, you have to be careful because it can cause other side effects, but at a low dose, 10 milligrams, 25 milligrams, that's a drug that's known to help sleep, help depression, and modulate pain. So it's a triple threat, basically. Right. Again, but it's limited by other side effects as the dose goes up. Sure. There are other medications. There's one called pregabalin or Lyrica that works in a different way. There's an antidepressant on the market that's been out for over 10 years, which is now generic, called Cymbalta or duloxetine. It's one of my favorite drugs ever produced. It has on-label FDA indications for major depression, generalized anxiety, and 3 pain conditions. So fibromyalgia, diabetic peripheral neuropathic pain, and chronic low back pain, in addition to depression and anxiety, all separate from each other. So these are 5 separate FDA approvals. So it's a quintuple threat. Yeah. But anyway, so there are pharmacologic agents that can cross over these various you know, disciplines, if you will, that are not addictive, that, you know, are legitimate treatments for more than one thing at a time. So I think those are, and there are more. I mean, we could go on, but it's, the idea is it needs a bigger picture view than simply treating insomnia. Because frankly, treating insomnia with a sedative, addictive drug like Xanax can actually make the depression worse. You see what I'm saying? Yes, so it's a moving, there are moving parts here, and in order to really do the right thing, one has to look at the big picture. Yeah, so definitely Gladys needs to go back to a doctor and say, this is not working right now. This is not a simple thing. I have multiple things wrong here. Can we pick an agent that can target multiple
Yeah. Okay.
targets, not just one.
Gotcha. Okay, Lori, I know that you are still on the line. We're going to take another quick break. When we come back, we will get right to your call, I promise. Stay with us, and don't forget, grab a pen and paper. We're going to be coming back with the referral line. If you would like to get a hold of Dr. Draud, we're going to give you that number, so stay with us.